Hello for everyone and good afternoon, Dr. Goldberg. We are happy to introduce our topic today of the next lecture of Principles of Surgery online course from Global Medical Knowledge Alliance. Our expert today is Dr. Goldberg, Assistant of Professor of Surgery at Harvard Medical School, who is specialized in gastrointestinal and general surgery. And it's our second meeting. And you are welcome, Dr. Goldberg.
Thank you very much. So I will talk today about Crohn's disease. I just want to let everybody know my family's from Lithuania, so not far from where you all live. They came to the United States 120 years ago. So anyway, so I have lots of family ties to Ukraine and Lithuania and Belarus, although they're not so friendly right now. So I will talk today about Crohn's disease, and I only have about 25 slides because last time we had so many questions, and I felt that the interaction was more beneficial for you. So I will elaborate on the slides, and there's plenty of time for us to talk. The other thing I was going to say is I'm going to compare this initially to a little bit about ulcerative colitis, although we'll have another discussion. And I think I even have a case in here that we can discuss. So basically, inflammatory bowel disease is inflammation of the intestine, and there are two major types. There's Crohn's disease and there is ulcerative colitis. And there's two main factors that differentiate Crohn's disease and ulcerative colitis is the distribution in the GI tract, the different clinical symptoms, and the associated symptoms that go along with them. One second. So in ulcerative colitis, it tends to be, or the clinical definition is it starts in the rectum. It's a continuous uniform spread of the disease from the rectum all the way to the cecum, but it is continuous. There are not skip areas, whereas Crohn's disease infects the entire GI tract from the lips to the anus, and there are skip areas. One of the things that's really, really important to understand about this distribution is once somebody is on treatment for the disease, whether it clinically looks like ulcerative colitis or clinically looks like Crohn's disease, once they're on treatment, there can be skip areas of disease. So somebody who presents with bloody diarrhea, you do a flex sig, they're on no treatment, the rectum is spared and the disease in the sigmoid colon, that's probably more likely to be Crohn's disease. Whereas if somebody starts with rectal and sigmoid disease, and then over time you start them on medicine and the rectum responds differentially better than the sigmoid or the descending colon, it's hard to call that Crohn's disease because different areas of the colon will respond differently to the treatment that the patient is receiving. So it's very critical to know how the patient presented when they weren't on treatment. The different clinical symptoms are also important. The ulcerative colitis generally tends to present with bloody diarrhea, lots of bowel movements, and tenesmus, not a lot of abdominal pain. It's mostly bloody diarrhea and urgency or tenesmus, whereas Crohn's disease presents more with mucus diarrhea and more with abdominal pain. So what are the genetic predispositions? So Northern European population, Scandinavian countries, people of Jewish descent from Northern Europe, but even the Sephardic Jewish people from the Middle East also have a much higher incidence of Crohn's disease than other ethnic groups. and people who are urban dwellers and high socioeconomic background. So I was in China a decade ago when you could still travel there, a couple years pre-pandemic, maybe 3 or 4 years pre-pandemic. And I was set to go during the pandemic, and it had to be canceled. But what we found in China, by speaking with the surgeons there, in the last 40 years, China has gone from a mostly agrarian society to a very urbanized society, and they have a massive increase in their inflammatory bowel disease, much higher percent than they used to.
Ale krótkiego.
So some of the theories behind inflammatory bowel disease is that some type of foreign antigen or lack of antigen causes immune dysregulation. What I have listed here are some viruses, some fungi, and even some bacteria. But some of this is that people are exposed to a certain bacteria and then they have an immune reaction, or lack of exposure to bacteria or other germs causes the body's immune system to attack itself instead of to focus on these invaders. Also smoking, very important. And ulcerative colitis is actually protective. Some people will get will put on a nicotine patch if they quit smoking and have a flare. Some people will keep smoking because they're having flares. And they know that if they smoke, it keeps their disease under control. I have one lady who's on her second lung cancer, but she won't quit smoking because she doesn't want an ostomy for her colitis. Exactly, Yulia. I saw your face. It's unbelievable. I told her, you're 80, we could take your colon out, and then you can quit smoking, and maybe you won't die from lung cancer. So you encounter all types of stories. But in general, Crohn's disease is exacerbated by smoking. It's much worse. And ulcerative colitis, for some reason, it's protective. Some other associations are non-steroidal anti-inflammatories. Family history is surely the #1 risk factor for another person getting Crohn's disease. And in these families, there's concordance for age of onset, location, and behavior of disease. I have a young woman who literally got fulminant colitis at the same age that her mother got it, in her late 30s, mid to late 30s, 36, 37, and has basically had a total colectomy with a ileostomy and then an ileorectal with a stricture. And her mother has an ileostomy for the last, 40 years. Her mother had her after she had her severe flare and kick up of ulcerative colitis. The thing that's interesting about that family is the father of the young woman is Jewish and her mother is Irish, and she gets it from her mother. And it's literally exactly the same pattern that her mother had, same age and everything. So there are some other gene associations. We see increased risks of Crohn's and colitis in patients with multiple sclerosis and rheumatoid arthritis. I think one of the big things for everybody to understand is there's an overlap between the genes that are causing ulcerative colitis and Crohn's disease. What we see is some people, when they're young, it appears that they have ulcerative colitis, and you do a proctocolectomy, give them a J-pouch reconstruction, and then they end up developing Crohn's disease in their J-pouch 5 years, 10 years, 20 years later. And generally, the current feeling is that there's really not genes that are just ulcerative colitis or just Crohn's disease, but there's a group of genes that influence inflammation and autoimmune dysregulation in the GI tract, and that there are multiple influences: stress, smoking, diet, viral infection, many things that either upregulate or downregulate different aspects of the genes, and that the pattern of how those genes are up or down regulated cause the person to present as if it were like UC or like Crohn's disease. So it's very important to realize that this, the pattern of what you see with the disease can change over the years. So what happens is you get mucosal inflammation, loss of integrity. So one of the other things about Crohn's disease and ulcerative colitis that's different is Crohn's disease is full thickness, ulcerative colitis is just the mucosa and submucosa. Also, the other thing is ulcerative colitis generally doesn't have perianal disease and Crohn's disease does. Okay. And as I mentioned before, ulcerative colitis is confined to the large intestine. So typically, you can also have the one pathologic feature that is generally considered indicative of Crohn's is a granuloma. So if you have granulomas on biopsy, that generally makes us think Crohn's disease. Certainly, you can have a granuloma if you have a crypt in the colon that is ruptured and you get a small abscess. You can get a crypt abscess granuloma. That can be seen in ulcerative colitis, but the vast majority of times, random biopsies that show granulomas are indicative of Crohn's disease. So you really have five things. You have confluent spread versus skip areas. You have full thickness inflammation. You have involvement of the small intestine or the upper GI tract. You have perianal disease. You have, I said granulomas, skip areas, full thickness, involvement of the upper GI tract, perianal disease, and then you have clinical presentation. So you really have five, and when I say clinical presentation, I mean bloody diarrhea versus mucousy diarrhea, crampy abdominal pain versus urgency. So you have to kind of look at all six of those to kind of determine whether you think it's ulcerative colitis or whether you think it's Crohn's. One of the big problems is that if people get labeled with Crohn's disease, they might not be able to get a reconstruction of their GI tract if they need their whole colon out. And that is very distressing to patients. They don't want to have to go to the bathroom in a bag for the rest of their life. Some people choose that, but the vast majority of people would like a reconstruction. So we tend to give people the opportunity, if there's mixed pattern between the six things I talked about, we'll tend to give people the benefit of the doubt. If they have, except for, a granuloma won't throw me one way or the other. If I think that they were diagnosed 10 or 15 years ago and we don't know the history very well, but they now appear to have confluent disease. So you biopsy the rectum, it shows colitis, but it doesn't look bad. The sigmoid colon and descending colon look bad. As long as they have evidence of colitis, that just means that segment of the colon is responding better. So the things that really make me concerned are severe perianal disease and small intestine involvement. The granuloma, the clinical presentation, the confluence or the differing ways that they respond to medicine are to me are less important, especially if it's somebody who wants a reconstruction. So it's very important to keep those things in mind and to have a thoughtful discussion with patients. If I think it's up in the air, if we call it indeterminate colitis, which we don't know, then I would have a very long discussion with the people, just letting them know that they're at a higher risk to develop Crohn's and to maybe lose a J pouch if they get a reconstruction. But what happens is all of the factors that I mentioned lead to mucosal inflammation, loss of mucosal integrity. If you guys remember from microbiology or from physiology, the gap junctions and the tight junctions and the desmosomes in between the cells of the small intestine, when you get inflammation, those break down. And that's one of the theories when people get a systemic inflammatory response from dead bowel or, when they start to get what we call leaky gut and they get septic, it's the same thing as happening in Crohn's disease. Those gap junctions, tight junctions, and desmosomes are breaking down, and bacteria gets access to the body and to the inflammatory cells and to the immune system, which causes a reaction. This is called the microbiome or hygiene hypothesis for the development of Crohn's and colitis. Urban areas are more sanitary, so there are less exposures. Then when you get an exaggerated immune response when you are eventually exposed. So this is very similar to ischemia. So here we go. I just mentioned this before, but I'll go over it again. It can affect the entire digestive tract, mouth to anus, more pain, watery, weight loss, obstructive symptoms with Crohn's. 3 major patterns. This is important. The colon alone is 30% of patients. Ileocolic disease is 50% of patients. That's the most common. And then you have about 15 to 20% are in the small intestine alone. Above, the colon will be fine. And you have about 1% of patients will have anorectal disease alone. I have probably anywhere from 5 to 10 patients in my practice that have such severe perianal disease, but they have no evidence of disease elsewhere. Now, usually after 5 or 10 years of they get their scopes, you'll find a patchy area in the rectum or the sigmoid. You'll do a biopsy, and aha, there's a granuloma. But it can take many years to get that diagnosis. But in a young person, especially if they have a family history of inflammatory bowel disease, or if they have really multiple fistulas, intersphincteric circular fistulas, blind tracts, not just a simple perirectal abscess with one fistula, but complex disease. The average person doesn't get complex perianal disease. That's just uncommon. It's probably much more common that you're anorectal alone Crohn's disease if you have very, very complex perianal disease. So once again, full thickness inflammation, you get strictures, fistulas, abscesses, you can have bleeding and anemia. As I mentioned, the histology shows granulomas, full thickness, creeping fat, and they will have ulcers generally in their mouth. So some inflammatory markers, CRP and sed rate are probably readily available just about anywhere. We look here in the States, fecal calprotectin. Do you measure that in the Ukraine?
Yes.
Yes.
Yes, you do? Excellent. Okay, so this is a much more accurate assessment of inflammation in the GI tract. It's a calcium binding protein, shows mucosal inflammation, and it's a stool test, but it works. It's much better than I've had people with fecal calprotectins in 300, 400, 500, and their CRP or their sed rate are barely elevated. So it's a much more sensitive and specific test of GI inflammation. These CRP and sed rate especially are non-specific if the patient has other disease like rheumatoid arthritis, lupus, and so that's where the fecal calprotectin is more accurate. So when do you do colonoscopy in somebody who has Crohn's disease? Generally, it's recommended every 6 to 12 months for Crohn's disease, and also after somebody has had surgery to look for anastomotic recurrence. In Crohn's disease, 6% of strictures will be malignant. So if somebody has a new stricture and it's in the colon, they need a scope. In the small intestine, they probably don't need a scope unless they don't respond to therapy. Any changes in the patient's symptoms should get a new colonoscopy, because remember, they're at increased risk for cancer. So if they have a change in symptoms, not only do you have to look to make sure that your medical management for the Crohn's is working, you also have to make sure that they haven't developed a new cancer. And if I'm doing an ileocolic resection on somebody, let's hypothetically say that, I always get a new colonoscopy if they haven't had one within the last year prior to me doing surgery, just to make sure that there's not another mass, a polyp, or another area in the colon that's inflamed that might need to be dealt with. So how do we medically manage people? Every 6 months we have a new medicine here in the United States, and I'm sure you have the vast majority of them in Ukraine, but they probably lag a little bit in coming out. But you have to understand these medicines. I would say the one point that I want to make is I never try to get people off any medicine except for the immune suppressants like 6-MP, Imuran, methotrexate, or steroids. Any of the biologics, don't have problems with wound healing. They actually keep inflammation under control, and the patients have less complications. So if somebody's getting their Remicade every 8 weeks and you stop their Remicade and do surgery in 12 weeks, you can expect to have more inflammation in the small bowel and in the colon. So what we typically do is we try to aim for them to get their Remicade and then be midway, or their Humira or whatever medicine, and be midway to their next dose. And that's when we generally try to time the surgery. But if the surgery is timed for 2 weeks after a Remicade dose and somebody's on 6 or 8 weeks, I would still do the surgery at that time. The idea is not to let the medicine run out completely and let inflammation take over. So the therapy is guided in general by several factors: the patient's age, the extent of the disease, the behavior and the symptom severity. So somebody who has mild Crohn's disease, they're 65 years old, and they have very localized disease in the ileocolic region. They've had the disease for 35 years and they have no obstructions. I might just have that person on a 5-ASA agent, right? Might not have them on a heavy duty biologic. It also depends if they're on their response to therapy and the risks of therapy. Some of these medicines we can't use because the patients have other cancers. They have, other contraindications to being immune suppressed. And then the other thing about how we do medical therapy is I'm always interested in the prior number of surgeries that the patients had and how far apart those surgeries have been spaced. So somebody who comes to see me, let's say who's 65, they've had Crohn's disease for 45 years, and they're having their first surgery, and they've lost no intestine. That person, I'm actually pretty inclined to operate on that patient earlier rather than later, especially if they're having symptoms, because they have all of their GI tract, and I'm only trying to get them another 20 years. Whereas if the 25-year-old comes to see me who's already had 3 operations and only has 230 centimeters of intestine left, I'm particularly concerned about operating on that patient. Because I'm worried about shortcut. So the number of surgeries, the length of time between the surgeries are all very important. So what are the indications for surgery for Crohn's? First of all, failed medical management. They're not getting better with medical management. So that could be many things. They've been on multiple medicines. We've tried all the biologic medicines. It could be that they're on steroids and we can't get them off steroids. It would mean that on an MRI or a CT scan, a patient has fibrosis and obstruction, but not active inflammation. So if you don't have active inflammation, the biologics and the steroids and the immune suppressants aren't going to work. If you have a fibrotic stricture, that's failed medical management, because the medical management won't make that stricture go away. So that's overwhelmingly the largest reason we operate, is failed medical management. Then we also operate for complications of disease. If somebody is bleeding, they have refractory anemia, even if they're on medications, refractory anemia is a reason to operate. Obstruction, as I just mentioned, with strictures. Somebody who has abscesses that can't be drained, okay, that would be a patient that we would definitely consider, because you can't give them immune suppressant or the biologics, even if the abscess is undrained. If somebody has a perforation, acute or chronic, and obviously anybody that has dysplasia and cancer. So, these are all generally the reasons we operate for any pathology process in the colon or small intestine, but that's how they apply to Crohn's disease. So what are some of the, can you guys see the top Crohn's medicines? You don't have this, the bar, are you, the green bar?
No, we don't. We can see everything clearly.
You can see everything. Okay. I have the bar. Let me see here. Let me get rid of this. I can't get rid. Oh, there we go. There we go. So anti-TNF therapy reduces the risk of surgery, as I talked about. The most common indication is failed medical management, failure to wean steroids within 6 months, obstruction. 25% of surgeries for Crohn's are from obstruction. Perforation is very rare. This is usually due to toxic colitis. The only operation, in my opinion, for this is total colectomy with ileostomy. I guess if they just had right-sided disease or ileocolic disease, you could do a right colectomy with an ileostomy. But in general, if somebody had, like I just operated on a patient of mine that I did a robotic right colectomy on for Crohn's disease, and they had a missed injury. So with the robot, I caused a tension injury on a piece of colon. I had to reoperate on day 2 because the patient was very sick. When we took out the anastomosis, everything looked great and there was no active Crohn's disease. So I hooked that patient together. Whereas when a patient who comes in with a free perforation and you don't know the extent of the disease and they haven't been on any medicines or treated, then I would do a resection with an ostomy in that patient. Okay, so that's what I would do. And rarely small intestine perforates. What's going on here? Oh, went too many times. Hang on. Okay, so bleeding is only 5 to 10% of the time that we operate for Crohn's. And typically, if somebody's bleeding and they have Crohn's disease, you would do the same thing as you would do in a GI bleed. You would do a tagged red blood scan, angiography, CT angiography, or endoscopy, because they might not be bleeding from the Crohn's. If somebody's in their 50s, they could be having a diverticular bleed. So you really have to localize the bleeding, especially in a patient with IBD, because they need to retain as much bowel as they can, because you're going to be taking out other parts of it because of the Crohn. So you don't want to take out bowel that's uninvolved if it's unnecessary. Abscesses, anywhere from, depending which literature you read, 5 to 25%. Abscesses due to microperforation, fistula, and then abscess formation. Most common in the ileocolic region. Generally, these are managed by antibiotics, drainage with interventional radiology, and then once the abscess is gone, we would take the patient to resection. Fistulas, enteroenteric and enterocutaneous, and bladder and vagina are fairly common, and that's anywhere up to 25% of patients that we would operate on. You only treat the symptomatic fistulas. So you would resect a diseased bowel. So say you had a transverse colon to stomach Crohn's fistula, and the disease is in the transverse colon, and the stomach, the fistula goes to the stomach, but the stomach is uninvolved with the colitis. You don't need to resect the stomach. You just need to make sure that the fistula opening is closed, right? So you could take off that fistula and resect the transverse colon and oversew the stomach. What I typically do is I just take a small stapler and I staple where the fistula from the diseased bowel joins the good organ. So if it's small intestine to sigmoid colon and it's a very defined fistula, I just put a transverse 3 centimeter or 30 millimeter stapler, and I staple on the colon, and then I resect the other piece of bowel. Same thing on the transverse colon. Staplers are a little more expensive, but they also save OR time than trying to oversew something. And that technique works really well to seal off the fistula. The uninvolved bowel will heal very well. It will heal on its own. Only with big fistulas or when I don't feel that the closure is satisfactory do I resect both the uninvolved bowel. When I mean uninvolved, I mean it doesn't have Crohn's disease, as well as the involved segment. So high-grade dysplasia in Crohn's, precancer. This is absolutely an indication for colectomy. The question is how much of the colon do you remove? So in the American Society for Colorectal Surgery clinical practice guidelines, I didn't write them, but I'm on the committee. And we should probably be due up for writing about Crohn's pretty soon again. If somebody has Crohn's colitis, the recommendation is for a proctocolectomy with an endoileostomy. That's the absolute indication because it's the maximal risk reduction operation. Personally, I think if the patient has, let's just say they had proctitis, okay, and proctosigmoiditis, and the rest of the colon is completely uninvolved. I think it's reasonable, with a good explanation and an explanation on how important it is to do surveillance on the patient, to do a APR and take out the sigmoid and the rectum and give them an end colostomy, but really watch them like a hawk. Like every minimum for a couple of years, I would do every 6-month scopes, and then I would go to every year if they hadn't, if their disease was under control, there was no active inflammation, but that person would spend the rest of their life getting at least 1 scope a year, because I've seen people that fall off the surveillance pathway and they end up getting another cancer. It's the same thing as somebody who has ulcerative colitis and has dysplasia in the cecum, but has very mild disease, and they're a young woman and they're interested in fertility and they don't want a J pouch, but they don't want a permanent ostomy. That I would tell somebody they could have a total colectomy if the rectum is uninvolved with an iliorectal and very, very, very close surveillance. But you have to let the patients know that there is a much higher risk that they're going to get another cancer and more dysplasia. Okay, so that's kind of, it's not hard and fast, but generally the recommendation is for total proctocolectomy for both. The difference is in UC, you have a reconstruction option, and in Crohn's, you don't. So you have to talk with the patient and what their preferences are. In America, we call this patient-centered surgery. We really want in the United States, I should say, because I was just in South America lecturing last June, and they were like, we're Americans too. And I said, I know, I've been friends with you guys for 20 years. Since I was in the US military, I was always in South America. And they were like, we're South American, you're North American. And I said, absolutely. So here in the United States, we have something called patient-centered care. We really, and we have one of the big things now is patient-centered. They're called patient-reported outcome measures, PROMs, PROMS. And we actually survey patients what they think about their surgery, how they did, and how does that affect their life, and how does that influence the choices they would make. I think that's valid everywhere, but it's a very, very big area of research right now in the United States. So in Crohn's disease, what are your goals? The goals are, it's non-curative, unlike ulcerative colitis, so you want to preserve as much small bowel as possible. Pre-op assessment is critical. Nutrition, make sure they're not malnourished. Malnourished patients have higher mortality, increased complications. Immunosuppression, get them off of steroids, get them off methotrexate, get them off Imuran. They don't need to come off their infliximab, their Humira, their Stelara, or their Entyvio. Anemia, you want to aggressively treat anemia. You want to look at their age, their prior surgeries. You want to look at somebody who has a DVT, somebody who has a central line. So patients who have elevated inflammatory markers, they're malnourished, they're on steroids, and they have anemia and or they have a DVT, what's the common theme there? All of those things show uncontrolled disease. So those patients are much more likely to have a complication, right? Because they're malnourished, they're on active inflammation. So it's all about active inflammation. Yes, the steroids cause poor wound healing, but somebody who can't get off the steroids has severe inflammation. Why would a DVT have any indication that a person is going to have a problem with the surgery unless you were worried about a PE? Well, actually, people who have uncontrolled inflammation are at a higher risk for a DVT. They also, if they have uncontrolled inflammation, they're more likely to be bleeding. Their bone marrow is not going to be working. They have anemia of chronic disease. The anti-inflammatories aren't working. So all of the things on this page are actually really indicative of a patient that has uncontrolled inflammation. They're going to be much more likely to have a complication with surgery. And as a result of that, you want to be much more prudent, cautious in what operation you do and whether you offer the person a temporary ostomy or not, and then come back once the disease is under control. Prior surgeries is very important. First time operation for ileocolic Crohn's disease, almost a 10% leak rate. Second time is about 18%, third time 25%. So if you're having your third operation for Crohn's disease, you have a DVT, you're anemic, and you're on steroids that we can't get off of, the complication rate is going to be very, very high, at least 25%. So when you think about all those things, what you want to do is you want to, in your mind, say, okay, this is somebody that I'm going to resect them and do an anastomosis, but I'm going to give them a temporary ileostomy upstream. Or I'm going to resect them and give them an end ileostomy, and then we'll go back and do a reversal in a year or two, or 6 months, or whenever, you know, the disease is under control. But all of these things are very, very important. So what are your operative choices for these patients? Resection with anastomosis for isolated disease, resection with anastomosis for multiple strictures in close proximity, resection with diversion, to, as I mentioned, to protect a distal anastomosis, diversion alone. So say you operate on somebody, first attack of ileocolic Crohn's disease, and they have really bad inflammation, and there's a huge inflammatory mass in the right lower quadrant. And you operate and you go in there and there's, oh, wait a second. There's now, they have 200 centimeters of good intestine. And then all of a sudden, the next 100 centimeters of good intestine is stuck to the inflammatory mass. And then you see the inflammatory mass and maybe there's 30 or 40 centimeters of Crohn's there, but you can't really peel off that 100 centimeters of good intestine, because you're going to injure it, you're going to cause enterotomies, you're going to have multiple repairs, they're going to be at risk for complications. In those patients, what you want to do is stop and just give them an ileostomy upstream. Go as far distal as you can until you get to the good bowel that's involved. I call that innocent bystander bowel involvement. If you have a lot of innocent bystander bowel involvement, what you want to do is give an ileostomy and leave everything downstream alone and continue with medical management. When you go back in 4 to 6 months, all of that innocent bystander small intestine that's uninvolved with Crohn's but was stuck to the inflammatory mass will no longer be inflamed or involved, because diverting the fecal stream makes the inflammation in Crohn's disease go away. Okay, so then you can save all of that 100 centimeters of bowel and just resect the involved segment. Okay, I've done that, you know, I've done 17,000 operations in my career, you know, and in the last decade, the vast majority have been for cancer and for IBD. And I would say I do 300 major cases a year. So the last 2,000 or 3,000 cases have almost been exclusively Crohn's, you know, ulcerative colitis and rectal and colon cancer. I've done this 3 or 4 times. So you're talking 1 out of 100 cases for inflammatory bowel disease. Do you need to do that for Crohn's? But something to think about, because you don't want to sacrifice all that good intestine. Stricturoplasty. So I like stricturoplasty, but I reserve that for patients that have had multiple surgeries. I do that for patients that have multiple strictures separated by long distances of bowel in between. Okay, so say somebody has 300 centimeters of intestine and they have 4 strictures, but every 4 or 5 strictures, but every one is 60 centimeters apart. You could do 4 resections, but you could also do 4 stricturoplasties. If they had 3 resections in a 30 centimeter segment and then 100 centimeters downstream, they had another stricture, you could do 2 resections, or you could do 1 resection in a stricturoplasty. I would probably do 1 resection in a stricturoplasty if they had only 300 centimeters of intestine instead of 500. If they had 500, I'd probably do 2 resections. So you have to mix and match depending on, once again, the number of surgeries, the age of the patient, the virulence of the disease, how many prior surgeries they've had, and how much intestine they have left. So medical treatment after surgery for Crohn's disease. The risk for recurrence of Crohn's disease after surgery. At 1 year, 15% of patients will already have recurrent disease. At 5 years, a third. At 10 years, 50% of patients will have recurrence. At 5 years, 50% of patients will have an endoscopic recurrence, not clinical recurrence. So you need to maintain patients in disease remission. It does 2 things. Number 1, it lengthens the time till the next surgery. It does 3 things. Lengthens the time to the next surgery, makes them have a better quality of life, and it also decreases the chance of them developing dysplasia. Controlling inflammation decreases the risk of dysplasia. Okay, so now here's a question. 35-year-old female with Crohn's colitis for 20 years. Multiple medications. Her disease is well controlled on infliximab. She's never had surgery. She now has a change in her bowel habits with bleeding and thin stools. Yulia, what would you do next?
Colonoscopy.
Okay, so you do a colonoscopy and you find George is right below you, so he's up next on the screen. So you do the colonoscopy and you find that you have right-sided dysplasia and you have descending and sigmoid colon dysplasia, but the sigmoid colon is free of disease. And she is not married and has no children. What would you describe as the options, Georgi?
We could probably resect, perform an ileocolostomy with a protective stoma.
Mm-hmm. Right, and you could offer her, depending on, I always offer patients a proctocolectomy. So what I describe to patients in this situation, whether it's UC or Crohn's, is I give them grades because everybody went to school and they know what a grade is. I tell everybody the A+ operation is a proctocolectomy with an endoileostomy. And the reason I tell them that is because that eliminates the risk of cancer and it treats the cancer and it treats the IBD. I fully well know that most people don't want that, but you will run into a patient who's more concerned about the cancer than they are about an ostomy. And that could be in the 20-year-old woman, the 30-year-old man, or the 80-year-old grandmother. Some people, like the one who continues smoking because she doesn't want an ostomy, she's like 80. Okay, so it really depends on every patient. But I offer them, I say, that's the A+ operation. That's the gold standard. And then I tell them, your disease is outside of the rectum. I said, your rectum is not involved. You have good medical control. It would be reasonable to do what you said, George, which is to do a total colectomy with an ileocolostomy or ileoproctostomy to the rectum. And then that you could give a diverting stoma or not do a diverting stoma. And I would explain those two options to the patient and see what the patient was interested in. Let me change that, George, or let's go to Justina. Are you there, Justina?
Yes.
So what would you do? We can't see you. Is she coming on? No, she's going to continue to hide. What would you do if the patient had right-sided dysplasia, transverse colon dysplasia, and rectal dysplasia, and it's high grade, and it's Crohn's disease?
I would probably offer proctocolectomy, and there wouldn't be much room for changing to more, let's say, better life style option. Because if she's got a rectal disease, it means that we have to remove the rectum.
I agree completely.
We could theoretically create a pouch, but for Crohn's disease, it's very risky.
I agree completely. This is not somebody that I would offer a J pouch to, because they're going to get disease. They're going to get disease in their J pouch and lose that, and then they're going to have lots of problems with fertility. They're going to have more problems with fertility with the J pouch that has Crohn's in it than they are with having a pelvic surgery without the rectum. So I would agree with you completely. So let me ask, I asked Yulia, who else is here? Let me see. Is it okay that I'm calling on people? Okay.
Yeah.
Mariana. So you have somebody that has ileocolic disease.
I'm sorry, maybe someone from our course participant, because Mariana is our organizing team.
Oh, I'm sorry. I don't know who's doing what. Okay, so Alexander? Good,
Good
there you go,
afternoon.
you're on. You're up, buddy. So somebody has ileocolic Crohn's disease. You did a resection. They now have a recurrence of their ileocolic disease. 50-year-old person, second recurrence, but they have most of their colon left. What would you do for that patient?
Maybe I will have the discuss with him about one more surgery, and how about this surgery will be, how risky this surgery will be.
So the colon is fine, the rectum is fine, the rest of the colon is okay. So I think you do another ileocolic disease. I think the question you have to ask yourself is if somebody's had one ileocolic disease. So I'm now going to ask Taras. Are you with us, Taras?
I'm also from organization team.
Oh, sorry. How about Vladislav? Vlad, are you with us?
Perhaps it's better to use conservative therapy.
Oh, okay. So the person's failed medical therapy. They have ileocolic Crohn's disease. Rectum is spared, but they also have disease in the distal transverse and the splenic flexure. Would you do 2 resections, or what would you offer that person? So they've had one ileocolic resection. They now have recurrence there, and they have disease in another part of the colon, but the rectum is fine. What would you offer that person? Taurus? Oops. Looks like he's gone. No? Oh, okay. Does anybody want to answer that question? Nobody wants to answer.
It's a hard practical question. So
it's a hard question. It's a very hard question. So I would say that you would get mixed responses here in the United States. Some people would say patients who've had one resection and then have recurrence of the disease that's multifocal in the colon should then get the rest of the colon out and get an ileorectal anastomosis because the rectum is uninvolved. And that then if they develop rectal disease, then they should have a proctectomy. Other people would tell you it's okay to do a resection and preserve colon. I would tell you that it depends on how sick the patient is, what their age is, and how they fared with medical management. In a person who's not done well with medical management, that they've had the last surgery 2 years ago, and they're not doing well with medical management, and then they're a little bit older, I would probably take out most of the colon. Whereas if somebody had had long period from their previous surgery to the current one, and they were doing fairly well with medical management, and we had options for medical management, then in that person, I would probably do segmental colectomies, as long as I was saving at least a couple of feet of colon in between the 2 anastomoses. But I would say that that is controversial, and that most people would say that the patient should have a subtotal colectomy if the sigmoid was involved, or a total colectomy if the rectum is uninvolved. Let's see, where are we? Okay, so I would say that those are the big questions about the big teaching points about Crohn's disease. What kind of questions do any of you have for me?
I have a practical question, if I may.
Yes, please.
Recently, we had a patient who presented to the emergency department with an abscess. We performed a CT scan, and we found multiple enteroenteric fistulas, and the fistula was complicated with an abscess. So we drained an abscess. She got better. The body temperature became normal, but apart from that, she had multiple liquid collections between the small intestine loops. But she was completely asymptomatic for that. So we transferred her to the gastroenterologist. What should we have done? Like, should we resect the involved small intestine with enteroenteric fistulas, or just continue medical therapy and observe?
Was the abscess perirectal or intra-abdominal?
The abscess was lying just underneath the skin, in the right inguinal area.
So it was an intracutaneous fistula, probably from a loop of bowel. What I would do is what you did, is drain the abscess in the OR. Those are what we used to call here in the United States a wind abscess. And those are very common from diverticulitis. People would get a big diverticular abscess and it would make its way out the inguinal canal. And then the patient would get the fistula, colocutaneous fistula, to the inguinal region. It sounds like this is what you had, but from Crohn's disease. And what I would say, what I would do with this patient is do exactly what you did: drain, antibiotics, and then try to get medical management. If the GI doctors were willing to do medical management, that's exactly what I would do. Stop sharing here so we can see each other. Let me hang on one second here and show. There we go. What I would do is I would try to get the patient under better medical control. But my guess is that fistula that's very complex would probably not close without a resection. So I would think ultimately that patient's going to need to be resected. The best reason, if the GI doctors will treat them medically, would be to get the rest of the intestine that's inflamed with the other fistulas in the abdomen to have less inflammation and better control for those areas.
So ultimately, she's going to need surgery after the inflammation drops down.
That would be my recommendation. But if the fistula completely closed and the patient was doing well, then you could choose to observe. Here, our gastroenterologists are very, very reluctant with active fistula and abscess to put people on the best medicine that we have, which is Remicade. So but that's a hard operation while the patient's actively inflamed. That's a tough case. Very tough. But I would do exactly what you did. The first thing is to get the sepsis under control with drainage, antibiotics, and then try to see if the GI doctors will treat to get the rest of the inflammation under control. Let me ask you, had this patient been on no biologics before, and was this a new diagnosis?
She was suspected with the Crohn's disease half a year ago, when she became symptomatic with some abdominal pain and stool habits. Her stool habits changed, but ultimately she presented with an abscess. She was on. She did not take any biologics, and what we did, we put her on combined therapy, which consisted of Humira and Imiran, and she got better.
She did. And you didn't have to do a resection?
No, we did not. We drained an abscess, put a drain in. It was the drain was in place for like 7 to 9 days, a bit more than a week. Then the fistula closed.
Great.
But yeah, the fistula closed, and then we transferred her to the gastroenterologist. We did not have to do any resections.
That's excellent. If they're willing to treat and it goes away, you know, I would be fine not resecting the patient. I'm glad that she was lucky. I would say that's probably only about a 30 to 35% of patients, about a third will be that lucky who have a bad fistula. I would say here that to me, the key that made this successful issue hadn't been on prior therapy. Right? So she's not on prior therapy. So then when you start her on therapy, she's going to have a much better response than somebody who's already been on therapy. So say this was a person who came in and they were on biologics and they had this develop. That patient's not going to do as well as the young lady that you're describing. So it's the same thing as somebody who comes in with perianal disease for their Crohn's, and they come in with perianal disease for their Crohn's, and they are already on biologics and their disease is out of control and they need a diversion. When you divert them with continued biologic therapy and give them a colostomy, their perianal disease will get much better, okay, and often go away. The problem is then they want their colostomy reversed, and then we reverse their colostomy, the perianal disease will come back. Whereas somebody who comes in and presents with bad disease, gets diverted, they're not on any good therapy, you start them on therapy, those patients will be much more likely to get reversed, their diversion reversed. So probably 95% of patients who are already on pre-existing biologic therapy who need a colostomy for bad perianal disease, less than 5% of them get a sustained reversal of their ostomy.
We have a few more questions. If yes, okay. Dr. Boyarsky, you're welcome.
Thank you. What is the acceptable extension of mesenteric excision during resections for Crohn's disease?
Very good question. So there's a current thought process that the inflammation in the mesentery is responsible for some of the Crohn's disease. I don't think that this has been proven. I try to remove the big inflamed mesentery if I can without running the risk of damaging other intestine or devascularizing other intestine. But I also have to balance that with the Crohn's mesentery is very thickened and inflamed, and you can often get a hematoma. And so I don't want a hematoma at the root of the mesentery, because then if I lose control of that hematoma, I'm at the root of the mesentery, and I'm more likely in trying to get that to stop to damage other intestine or devascularize something else. So I try to, you know, do the best I can, but until there's evidence that we absolutely have to resect that because that's the driver of the inflammation, I try to be cautious when doing that.
Thank you.
Of course. Victor?
Thank you for the answer. And one more from Dr. Czerwonoczenko.
Thank you for your lecture. If we have a patient with right-sided colon cancer and we are planning to do a right colectomy, but also intraoperatively we suspect an ileocecal Crohn's disease, but we don't know exactly the extent of the disease or onto the small bowel. Is there a place for anastomosis in such cases, and if it is, in which cases we can perform an anastomosis for such a patient?
If you think there's, yeah, I think in a patient like that, I would do a right colectomy. I would treat the cancer first. Right. So if the patient has a right-sided colon cancer or a cecal cancer, and you think they have Crohn's disease, I would do, if the Crohn's disease was isolated to the ascending colon, then I would just do a formal right colectomy because you have to treat the cancer, right? You need to get all the nodes. Whereas if the Crohn's disease were going into the transverse colon and it was much more extensive, then, you know, I might do a subtotal colectomy. It just depends if, this is a hard question because they haven't been on treatment yet, right? So if they're not on treatment, the question is, do you want to leave a blind stump of transverse colon with active Crohn's disease in a patient who's not treated, who probably needs chemotherapy? The answer to that's probably no, because then they have a leak or an abscess where they're on chemo. It's going to be, you might delay their chemo. So I would probably try to treat both. Hopefully it would be limited to the right side and it would be easy. But if not, I would probably do more aggressive resection. It's interesting you asked that because I just operated on a guy with UC that was uncontrolled who had a perforated appendiceal cancer with pseudomyxoma peritonei. And so I did a right colectomy to treat the pseudomyxoma. I debulked the pseudomyxoma and I left him with an ileostomy because he also had Hodgkin's disease and needed treatment for his Hodgkin's disease. And I didn't want to delay his cancer therapy, and his UC was out of control. He was on double biologic therapy for his ulcerative colitis and was still having lots of symptoms. So very similar question to yours, not Crohn's, but UC, and it was uncontrolled. So I did a little bit bigger operation, and he's in his 70s. So, he's probably never going to get hooked up. I didn't do a proctocolectomy because it was a much bigger operation. And, if his disease gets under control in the rectum, his colitis was confined to the rectum. So he needed the right colectomy for a different reason, not for the colitis. These are very challenging. Thankfully, there's not very common problems, Victor.
Great.
Thank you
for the answer, Dr. Goldberg. Maybe someone else have a question? You are welcome.
Oh, and my name is Joel. So for some reason, my son's name is appearing here. He's Samuel. I just noticed this says Sam Goldberg.
We know it, but I think it's not a problem.
Any more questions from anybody?
I have a question. So
Yes.
I recently had a emergency case. We had an emergency admission of patient in her 50s. She came in with bowel obstruction, and on the CT scan there was a area of inflammation and stricture in her terminal ileum. From her past medical history, she had the ileocecal resection for the Crohn's colitis of terminal ileum like 15 years ago. And for the last 5 years, she was off any medical therapy. She just neglected it. So what would be the best kind of solution for this problem?
And she now has a stricture in the ileum?
Not definitely a stricture. There was a stricture probably in her ileum, but not like a long-term stricture. There was an area of inflammation. Her CRP was like 150. By the way, we started her on antibiotics, and after, let's say, the first dose, or like within 12 hours, the obstruction resolved. So she passed bowel. So she opened her bowels, but.
Yeah, this is hard. We typically, when people come in with a stricture and haven't been on therapy, and we're pretty convinced we know they have IBD, we would do exactly what you did. Antibiotics, steroids if there's no perforation, and hopefully the inflammation will get better, and then we would go to biologic therapy. I would also scope that patient pretty early in the course to make sure that it wasn't cancer.
Okay, so even if it is only in the terminal ileum, you wouldn't go for surgery first again, as she had an ileocolic resection already.
I mean, it depends how close it is. If it's within 10 or 15 centimeters, I might resect. If it was way upstream, I would probably still try to treat the disease biologics first and steroids.
One last question. What if this? How long would you wait for could you wait for the obstruction to resolve with biological or medical therapy? Like, well,
in an obstruction like this, we would start with steroids because they'll work much quicker than biologics. If the patient didn't get better with steroids within 7 to 10 days, I would probably offer them surgery.
Okay, so you could wait 7 to 10 days for the medical therapy to work. Okay, perfect. Thank you so much.
For steroids, not for biologics.
For steroids.
Biologics would take longer.
Okay. Thank you so much.
Of course.
Thank you very much for the answer and for the interesting question.
Any
Thank
other
you,
que-
Doctor.
No more questions. Okay.
Thank you, Dr. Goldberg. It's an excellent lecture and excellent discussion. Thank you all. Thank you, participants, for the active participating in our discussion. And I hope we will see in the next lectures.
I think 22 April is going to be on ulcerative colitis.
Great. We were waiting for the lecture. And thank you. Have a nice afternoon and have a safe evening for Ukrainian and for Ukraine. Thank you very much.
Absolutely. Thank you very much. Bye-bye, everybody.